Welcome to my presentation on Charles Bonnet syndrome and its treatment. My name is Okan Ekinci. I am a psychiatry associate professor in Turkey. Together we will explore this intriguing condition, its impact on patients, and the effective strategies for managing and treating it. Let me delve into the complexities of this syndrome with clarity and insight. We trace the origins of Charles Bonnet syndrome (CBS) to a fascinating historical account. Charles Lullin, the grandfather of Swiss naturalist Charles Bonnet, experienced striking visual hallucinations, vividly perceiving birds' carriages, buildings, and individuals despite being visually impaired. Bonnet meticulously documented these occurrences, noting Lullin's remarkable ability to distinguish these illusions from reality. Nearly 2 centuries later, Georges de Morsier built upon Bonnet's work, introducing the term Charles Bonnet syndrome, formalizing recognition of these compelling phenomena, substantially under-recognized due to societal stigma and frequent misdiagnosis. A deeper understanding of CBS not only normalizes this phenomenon but also provides clarity and reassurance for those experiencing it. Rare visual hallucinations, as seen in Charles Bonnet syndrome, present a unique challenge tied to visual impairment. They manifest as vivid, recurring images, ranging from simple patterns to intricate scenes, often startling those who experience them. Despite affecting a significant percentage, estimated between 10 to 40% of individuals with severe vision loss, this condition remains underdiagnosed. By recognizing the diverse nature of these hallucinations, we enhance our ability to provide timely reassurance and accurate diagnosis. 4. We recognize that diagnosing complex visual hallucinations hinges on 3 critical factors: verifying their connection to vision impairment, confirming the absence of psychiatric or cognitive conditions, and identifying their clinical presentation. By fostering trust and carefully gathering patient history, we can overcome reluctance to disclose hallucinations. Utilizing ophthalmologic assessments allows us to pinpoint the root cause of vision loss, while neurological exams and neuroimaging offer clarity in atypical cases, ruling out structural brain issues. Differential diagnosis requires vigilance, as distinguishing these hallucinations from psychosis, neurodegenerative disorders such as Lewy body dementia, delirium, epilepsy, medication side effects, or migraine aura depends on preserved insight, the absence of multisensory hallucinations, and a clear link to vision loss. Age plays a pivotal role in the prevalence of CBS. As we age, vision decline and cognitive shifts become more common, making older individuals, especially those over 60, more susceptible. Social isolation profoundly affects our mental and cognitive well-being. Loneliness, often overlooked, acts as a potent trigger for hallucinations. Chronic isolation not only intensifies psychological symptoms but accelerates cognitive decline, further amplifying the severity of hallucinations. By fostering meaningful social engagement, community-based intervention programs have demonstrated their effectiveness at reducing hallucination frequency. We explore how Charles Bonnet syndrome emerges as a phenomenon of release hallucinosis attributed to visual sensory deprivation. Neuroimaging studies reveal heightened activity in the visual association cortex, specifically Brodmann areas 19 and 37, even in the absence of direct retinal signals. The mechanism parallels auditory phantom perceptions seen in tinnitus or somatic hallucinations in phantom limb pain. Among the prevailing theories, the deafferentation hypothesis proposes that when input from damaged retinal or optic pathways is lost, higher-order visual networks become disinhibited, spontaneously generating visual imagery. We recognize that the perceptual release hypothesis highlights the adaptability of the visual cortex when deprived of normal stimuli. It strives to reconstruct absent visual input, resulting in internally generated imagery. Furthermore, neurochemical mechanisms, including changes in cholinergic and dopaminergic transmission, play a role in regulating the vividness and occurrence of these experiences. Importantly, the absence of structural brain disease and the resolution of hallucinations following restored vision, such as through cataract surgery, reinforce the concept of peripheral triggers as a key factor in the phenomenon. when we lose visual input due to conditions like macular degeneration, glaucoma, or optic neuropathy. The pathways connecting the retina to the visual cortex are disrupted. This loss leads to a decrease in the normal flow of sensory information. In response, the visual cortex undergoes cortical disinhibition, increasing its excitability, particularly in the visual association regions. This heightened activity triggers spontaneous neuronal firing, creating vivid visual hallucinations that our brain interprets as real imagery. We interpret functional neuroimaging findings as evidence that hallucination episodes are linked to heightened metabolic activity within visual recognition pathways, especially the ventral stream. This region, encompassing the ventral occipital lobe, fusiform gyrus, and inferior temporal cortex, plays a pivotal role in identifying faces, objects, and patterns, explaining the detailed, elaborate imagery often experienced during hallucinations. Unlike the ventral stream, the dorsal stream, tasked with spatial processing, appears less engaged, aligning with the stationary and non-interactive characteristics of such phenomena. Let's explore how neurochemical mechanisms can influence visual experiences. Dopaminergic excess in the brain's visual association areas enhances perceptual processing, which may lead to visual hallucinations. This heightened activity is complemented by serotonergic imbalances, particularly disruptions involving 5-hydroxytryptamine 2A receptors, resembling patterns observed in psychosis or LSD-induced states. Additionally, weakened GABAergic inhibition in the occipital cortex diminishes the brain's ability to regulate excitatory signals, potentially allowing vivid visual imagery to emerge. As we navigate the complexities of cognitive and perceptual theories, we observe the profound interplay between sensory input and the brain's internal mechanisms. The perceptual release hypothesis highlights how our minds compensate for insufficient visual information by relying on stored memories, illuminating the familiarity often seen in hallucinations. Meanwhile, the predictive coding model demonstrates our brain's relentless pursuit of understanding, showcasing how the absence of sensory feedback can amplify internal predictions, morphing them into vivid hallucinations. Furthermore, neural network instability underscores the delicate balance between bottom-up sensory processing and top-down cognitive control, revealing how disrupted input fosters autonomous visual activations. Together, these theories provide critical insights into the mechanisms shaping our perceptual experiences in conditions like CBS. Management of Charles Bonnet syndrome requires a tailored approach based on symptom severity. For milder cases, offering reassurance is often sufficient to address the experience. For those of us facing more pronounced symptoms, effective strategies include using behavioral techniques, such as deliberately blinking or shifting focus quickly between objects to disrupt hallucinations. Pharmacological interventions may also assist in reducing the intensity of these perceptions. Above all, a compassionate and informed clinician ensures the patient feels supported and understood throughout the treatment process. Through psychoeducation, we empower ourselves and patients with a clearer understanding of Charles Bonnet syndrome, fostering a foundation that mitigates anxiety and aligns expectations. By incorporating mindfulness practices, we cultivate resilience and effective coping strategies, leveraging evidence from the latest meta-study on mental health interventions. Cognitive behavioral therapy allows us to collaboratively reframe perceptions and equip patients with practical tools to navigate hallucinations, reinforcing comprehensive care principles and enhancing therapeutic outcomes. Pharmacotherapy plays a crucial role in managing symptoms, despite variability in patient responses. Acetylcholinesterase inhibitors, commonly applied in Alzheimer's cases, have demonstrated potential in alleviating hallucinatory episodes linked to Charles Bonnet syndrome. When antipsychotics are employed in select scenarios, vigilance is required to address potential side effects. At the same time, advancing research continues to explore novel therapies targeting the neurochemical mechanisms underlying this condition. This case presents an elderly male experiencing acute visual hallucinations, characterized by sudden onset and lack of recurring patterns. The absence of psychiatric disorders in his familial history adds a layer of diagnostic complexity, underscoring the need for thorough evaluation to uncover potential underlying causes. As we evaluate cases like these, understanding the absence of psychiatric disorders allows us to refine our focus. By eliminating potential psychological origins, we shift our attention toward neurological or ocular causes, ensuring a precise diagnostic approach. This step underscores the importance of thoroughly addressing psychiatric history, as visual disturbances often arise from complex medical interactions that warrant targeted investigation. Macular degeneration, a primary ocular condition, significantly diminishes vision and stands as one of the leading contributors to visual impairment. Affecting over 10 million individuals in the United States, its prevalence underscores its profound public health significance. This condition can disrupt normal visual input to the brain, sometimes leading to visual hallucinations as the brain attempts to compensate for reduced sensory information. Our assessments highlighted mild ataxia during neurological exams. The MRI analysis further confirmed this conclusion by showing left cerebellar stroke. These findings reinforce both neurological and ocular explanation for CBS in this patient. Cerebellar infarction may disrupt our brain's ability to integrate sensory information, potentially triggering Charles Bonnet syndrome. This unique presentation underscores the role of neuroplasticity as the brain adapts to damage, revealing CBS symptoms. Awareness of such links is essential for timely diagnosis and effective management of CBS, ensuring better outcomes for patients experiencing these profound changes. Cerebellar infarctions significantly influence how we process sensory information, often playing a role in the development of cortical blindness syndrome symptoms. Advanced imaging, such as MRI scans, illustrates a direct relationship between cerebellar damage and the intensity of visual hallucinations observed in these cases, emphasizing the cerebellum's crucial role in sensory regulation and perception. Cerebellum also contains fragmented retinotopic maps and communicates with visual networks. We recognize the importance of empowering patients through education, fostering confidence, and dismantling misconceptions about visual phenomena. By integrating perceptual training with informative strategies, we enhance therapeutic effectiveness and promote meaningful improvements in outcomes. Vision optimization and behavioral interventions empower us to manage the challenges of Charles Bonnet syndrome effectively. By engaging in targeted activities, such as focusing attention on specific tasks or altering our environment, we can mitigate hallucinatory episodes. As a last resort, we initiated brexpiprazole at 0.5 milligrams per day as an intentional low starting dose, prioritizing close observation of patient responses to balance effectiveness with safety. Within just 1 week, patients typically notice measurable progress, a testament to the treatment's rapid onset of action. Feedback reveals noteworthy improvements in the frequency and severity of hallucinations. Moreover, clinical evidence confirms a 35% reduction in visual hallucinations during this initial phase, underscoring both the reliability and efficacy of this therapeutic approach. We discontinued medication after 2 months without symptoms returning, emphasizing the effectiveness of the treatment plan. By tapering doses gradually and adhering to medical oversight, we mitigated the risk of relapse. Brexpiprazole presents a promising avenue for addressing CBS-related challenges. We recognize its potential to ease anxiety symptoms, a prevalent concern among CBS patients. Its tolerable side effect profile suggests suitability for sustained use. Let us address an often overlooked phenomenon in visually impaired individuals, Charles Bonnet syndrome, or CBS. Studies show it affects 10 to 40% of those with severe vision loss, highlighting the scope of this condition. People with eye diseases such as macular degeneration or glaucoma are particularly vulnerable, which calls for heightened medical vigilance. Yet CBS remains significantly underreported in clinical settings due to insufficient awareness both among healthcare providers and patients. This gap in recognition underscores the importance of proactive education and diagnostic practices to improve care for those at risk. Thank you for listening. If you have any questions, I'd be